I think that by now we all agree that ILM flap is an improvement in the technique and it adds success. So the purpose of my talk is not to give you result, but it's to learn how to make it better. So how to make it better and how to answer open questions. So how do we do the peeling today? We do the peeling to close a hole, and we make it in two different ways. It could be a temporal flap on top of the hole. It could be a 360 flap on top of the hole, either just lying on top or pushed inside the hole. We also make ILM peeling to avoid inducing a macular hole with the foveal sparing technique. Let's go through all of them as an example. This is actually a traumatic macular hole in a child. The choice of the technique was a 360 ILM peeling. So the ILM is peeled all around. And then the peeling, the flap is trimmed. So the first question is, how large should be the peeling? How much should we trim? How large should be the flap? Have you made up your mind? Is there a difference? Does the amount of ILM that we leave into the hole prevent visual improvement? So my guess, my observation is that the ILM flap does not prevent a visual recovery, because this patient can see and can see very well. And they don't see the flap. This is one of my first concerns. Will the patient see the flap moving? I don't know if it makes the difference to have a large flap or not. I would like to hear your ideas. This is an example. You can see on the picture on the bottom, this flap like floating around. I wonder if it makes sense, if it has a role or not. As I was saying, now I'm doing microperimetry in every case that I operate, and I'm learning a lot. And I'm observing an improvement, not only in macula, in visual function, in visual acuity, but also in microperimetry. This is another example. We can see that there is a remodeling in the follow-up. So in the middle, you see 1 month post-op. On the bottom, you see 6 months post-op. The retina is changing. So is the retina, the ILM flap, working as a scaffold for the retina to remodel in time? Not only full-thickness macular hole, but also lamellar macular hole can be treated with the flap. These are very difficult to close. These are high myopic patients with deep lamellar hole. If you do the regular classic peeling, your chance of ending up with a full-thickness macular hole is very high. If you leave a flap of ILM, they do close, as you can see in the post-op. Of course, I added the buccal because you know that I'm treating the staphyloma with the buccal, but that's not the point of my talk. And you can have an improvement in microperimetry as well with the central fixation. So my first conclusion is that the ILM flap does not prevent visual recovery. I think it is necessary, although I don't know exactly which is the best way of doing it. I don't know if the trimming is necessary and how much. And I don't know whether it's better to just leave the flap on top of the hole or just to push it inside. What about the temporal flap? So in this case, we don't have to peel all around, just on one side, and then we just leave the flap on top of the hole. And in this case as well, you can see the same remodeling of the retina over time. But observe, like in the picture in the middle, where the flap touches the retina is regular. On the bottom, you can see that where the flap does not touch the retina is more irregular. So is this correlated to the presence of the flap? Again, we can see anyhow an improvement in vision and in microperimetry, even with the temporal flap. I observe a higher rate of dislocation, postoperative dislocation of the flap. Like in this case, you can see with the OCT that the flap is dislocated and the macular hole is still closed. So with the second surgery, I reposition the flap on top of the macular hole. And since this case, I started to stain again under air, just to see in the final stage of surgery exactly where the flap is. So you will see a new staining of with dye under air, just to see where the flap is. I don't know if I can move on the video. Yeah. So in this case, if you stain again, you know exactly where your flap is moving. And then you can see after the repositioning, the hole is closed. And with the foveal sparing technique, this is a different case. You don't have a macular hole since the beginning. You don't want to induce a macular hole. So basically, you peel the ILM all around, and you just leave the flap on top of the hole. Here you see the intraoperative OCT. You will see the flap of ILM just on top of the fovea. This was a very difficult case, and I think that the ILM sparing technique prevents a macular hole. So anyhow, I can move on where you know how to make the autologous transplantation. I would like to share with you your impression and your result. Let me finish with this beautiful picture that Dr. Rino Fresina just showed me. You see the histology of the retina after peeling, and you see on one side the peeled retina and on this side the non-peeled retina. Here is higher magnification. On the peeled retina, the Mueller cell seems to be damaged. So probably the sparing technique can also protect the Mueller cells and the cell structures. So just open question to be discussed, okay?
So, any question? Yep. Jersey?
I'm sorry. You see, you put into one presentation so many subjects that is difficult.
It's all about ILM peeling, actually, the new
not
technique.
Exactly. Everything, every 2 slides you had different subject, at least what I understand.
Okay.
Let's begin with trimming of ILM.
Yes.
We stopped trimming ILM maybe 6 years ago.
Okay.
Because why we decided to trim ILM? We learned from previous EVRS meetings that presence of ILM may induce formation of epiretinal membranes. So that was the reason that it may be in first 200-300 cases, I decided to trim ILM to decrease the risk of epiretinal membrane formation. But then we observed no epiretinal proliferation in those cases, so we decided to stop trimming because it is risky and you may lose the flap.
Yeah.
Second, of course, if you peel ILM, you damage Mueller cells. And it was also presented in our paper about temporal inverted ILM flap that after surgery we have a nerve fiber layer, or as you can call it, DONFL, as Tadayoni gave this name, but never mind how you call it, it is nerve fiber layer defect, which happens in area when ILM is already peeled. So that was the reason of giving temporal ILM flap without peeling the rest of ILM, because we have less surgical trauma to those cases. And we presented not only that after complete ILM peeling we have nerve fiber layers all around the fovea and in temporal flap not, but also we observed that the nerve fiber layer defects do not happen only after surgery. They increase over time in 12 months period of time after surgery.
So basically, a temporal flap is enough, and it's not needed to be trimmed.
And as big as
because we've seen a whole kind of peelings today, and we have to know what to do.
But the last comment to lamellar macular holes. Lamellar macular holes, never mind if you call them classical or LHEP, they are epiretinal membranes, and you must peel them carefully. And this is just careful peeling of ILM from the periphery towards center. It prevents iatrogenic macular hole formation.
Exactly.
And iatrogenic macular hole formation is, in my opinion, just from excessive surgery and too dangerous surgery. It is not because of epiretinal membrane.